We are live on YouTube. Ma'am, I'm starting the recording.
Yeah, sure.
So, ma'am, we are live on YouTube as well as have started the recording, ma'am. So, this is Ranjit Sahu, Marketing Head with Walter Bushnell. So, Walter Bushnell Healthcare Foundation invites you to a live webinar on luteal phase support. We have with us our honorable speaker, Dr. Anadip Chandi. And apart from it, we'll have a paper presentation by Dr. Ruxana Farooq on correlation of cervical pap smears with histopathological diagnosis in cervical lesions. Before moving ahead, I want to share about the credentials of our speaker. When I talk about Dr. Anadip Chandi, she is a consultant reproductive medicine and laparoscopic surgeon, Valley Fertility Center, Srinagar. She has an experience of more than 11 years in the field of obstetrics and gynae. She has completed her MS in Obs-Gynae from BD Sharma PGIMS Rohtak, Haryana in 2014, after which she did her DNB, fellowship in reproductive medicine and fellowship in gynecology endoscopy under ICOG program. She has completed a senior residency from Government Medical College and Hospital Chandigarh and worked at post of research associate in PGIMR Chandigarh as well. There are many international and national publications under her name. She received Young Scientist Award in the year 2021. She has been a very active participant in teaching and academics. Her chief interest areas are infertility workup and management, poor ovarian reserve, PCOD, fibroid uterus, and gynecology endoscopy. With this, I hand over the session to Anadip ma'am to take it forward. Over to you, ma'am.
Thank you very much for this generous introduction. I thank Walter Bushnell for giving me an opportunity to present on a very important topic of luteal phase support. So we'll be talking today as on evidence-based medicine. So let me start with the presentation now. So welcome everybody. So luteal phase, why luteal phase support is so important? So we all know that luteinizing hormone, that is LH, it has a very important role in luteal phase. It is totally responsible for the hormonal release of corpus luteum, upgradation of growth hormones, upgradation of cytokines involved in implantation, stimulation of LH receptors in endometrium. So in today's presentation, we'll be discussing what is luteal phase defect, that is definition of luteal phase defect, its diagnosis, what support we can give in the luteal phase, that is what are the indications of luteal phase support, drugs used for luteal phase support and modified luteal phase support, and what is the best timing of luteal support and how long to give luteal support. So coming on to luteal phase defect. Luteal phase defect in natural cycle is defined if the serum mid-luteal progesterone levels are less than 10 nanogram per ml. There is another definition which is based upon endometrial biopsy report, that is a lag of more than 2 days in endometrial histological development compared to the expected date of cycle. It is also considered as defective luteal phase. So the prevalence of luteal phase in natural cycle is usually around 8.1%. So luteal phase defect is characterized by failure to develop fully mature secretory endometrium, and it might be due to decreased progesterone receptor in the endometrium or inadequate progesterone secretion from the corpus luteum. So what are the methods which can help in diagnosing luteal phase defect? There is one basal body temperature charting, which is not usually used because it is inaccurate and inconvenience is there in diagnosing through this method. Then there is mid-luteal serum progesterone level, and again there is endometrial biopsy. But the final diagnosis always remains controversial. So coming on to the first method of diagnosing the luteal phase defect, that is serum progesterone levels. Serum progesterone is usually secreted in pulses. That is, it reflects the LH pulse of the body. So it usually fluctuates within, it usually is secreted after every 30 minutes, and it fluctuates up to 8 folds. So after ovulation in a non-pregnant cycle, it peaks at around 6 to 8 days after ovulation. And there is no cutoff being given below which the support should be added. Now, what happens when pregnancy is there? The embryo, it usually releases HCG hormone, which then acts on the corpus luteum, and then corpus luteum produces progesterone. Now, decreased progesterone levels in early pregnancy, that might be due to non-viable or extra uterine pregnancy, abnormal HCG stimulation of the corpus luteum, or inadequate hormone secretion by the corpus luteum. Another method is endometrial biopsy. It actually helps in identifying the microscopic appearance of the luteal phase endometrial development, and it is considered a gold standard in diagnosing luteal inadequacy. It detects the abnormalities of the endometrial maturity, as there is which can be due to inadequate ovarian hormone secretion or intrinsic endometrial abnormality. However, there are certain disadvantages of doing endometrial biopsy just to diagnose luteal phase defect. One is that there is no clear-cut applicable criteria which can define luteal phase defect, and the criteria which are being defined, they are very complex. Endometrial maturation may delay in up to 25% of the biopsy cycles, even in regular cycles of fertile women. Also, there is high intercycle variability. This means that in one cycle, the endometrial biopsy may show normal report. However, if done in the next cycle, it may have a abnormality shown. Also, there are high false positive and false negative results. There is no evident impact of histological dating, even when the progesterone falls to 3 to 10 nanogram per ml in the mid-cycle phase. So coming on to luteal phase support. So once you have detected that there is a luteal phase defect, you need to give a support. This term actually is used to describe the administration of medication with the aim to support the process of implantation. Now, what are the indications of luteal phase support? Luteal phase support can be used in natural cycle or ovulation induction or IUI cycle, or in ART cycles. Now, in natural cycle or ovulation induction cycles, it is mainly used in subfertile couples, or during timed intercourse, or recurrent pregnancy losses, or in patients who are obese with PCOS or hyperprolactinemia, or in which there are high hormonal imbalance, that is, the patients are underweight or are going for strenuous exercise on daily basis. In ART cases, the luteal phase support as such is an important treatment, and it is usually used in all cases irrespective of the diagnosis. However, in certain diseases like endometriosis or hypogonadotrophin disease, or in ovarian aging, or in when we use high dose of gonadotrophin with or without GnRH analogs, or during fresh embryo transfer or frozen embryo transfer, or in cases of recurrent pregnancy losses, the role of luteal phase support becomes even more important. So let's talk about what the evidence say regarding luteal phase support in various conditions. So first, we are talking about luteal phase support in spontaneous ovulatory cycle to prevent miscarriages. What does the evidence say? In 2013, Cochrane meta-analysis proved that the luteal phase support doesn't help in preventing miscarriage in women conceived naturally who have no history of miscarriage in the previous pregnancies. However, when we talk about recurrent pregnancy losses, which is seen in around 8 to 12% of the normal pregnancies, we see that 40% of the recurrent pregnancy losses, they have luteal phase defect. So in such cases, the luteal phase support actually helps in preventing miscarriage in women with recurrent miscarriages. That was proven by Cochrane meta-analysis in 2013, and that was again supported by a Cochrane review that was released in 2018, which shows a slight benefit in live birth rate of around 11% for women who receive luteal phase support with the help of progesterone. So coming on to luteal phase support in IUI cases. So when IUI is done with the help of clomiphene citrate and gonadotrophin stimulation, luteal phase support actually does not help in improving the clinical pregnancy rate. However, when the age of a woman is more than 30 years, the luteal phase support again helps in increasing the pregnancy rate, as the pregnancy rate was seen higher in older women of more than 30 years as compared to the younger women when progesterone was used as a luteal phase support in such cases. When IUI is done with gonadotrophin alone, the luteal phase support actually increases the pregnancy rate with a difference of 12.3% versus 7.9% when the luteal phase support was used or not used. However, this was not statistically significant, but higher pregnancy rates were seen when the luteal phase support was used in cases where IUI was done after stimulating with gonadotrophin. Now, again, a meta-analysis was released in 2017, which actually compared the pregnancy rates after various stimulating agents, that is gonadotrophin or gonadotrophin plus clomiphene or clomiphene alone. And if you see this forest plot and see the diamond, the luteal phase support was favored in cases of when the gonadotrophin alone was used. However, when clomiphene was used along with gonadotrophin or as a standalone, the luteal phase support was not very much significantly important in such cases. However, it was showing higher trends when it was used along with gonadotrophin. Coming on to luteal phase support in ART cases, we all know in ART cases, that is IVF cases, luteal phase support is a must, especially in frozen embryo transfer and in fresh embryo transfer cases. So why it is so important? Because in stimulation, in hyperstimulated cycles, there is luteal phase abnormality, which is because the function of luteal corpus luteum is compromised by the process of follicular aspiration of the oocyte retrieval. Multifollicular development is seen in ovarian stimulation, which again hampers the luteal phase of that cycle. And there is altered LH pulsatility due to GnRH analogs itself, and continuous gonadotrophin, when used, it impairs the LH pulsatility irrespective of the GnRH analog used. So if you see this graph, in a hyperstimulated cycle, the luteal phase, which is normally seen as of 14 days, it becomes shorter and it is seen as 7 to 10 days. So when we see when we compare the different IVF protocols, that is long agonist protocol or short antagonist protocol, the prolonged in agonist protocol, the prolonged suppression of pituitary LH secretion causes luteal phase inadequacy. However, in GnRH analog antagonist protocol, there is faster recovery of the LH production. However, still the pregnancy rates were significantly reduced in such cycles as well. So what are the drugs which are used in luteal phase support? So the aim actually is to save the corpus luteum and to supplement the products of the corpus luteum secretions. So the drugs which are used in the luteal phase are progesterone, which is the main drug, HCG, GnRH agonist, estrogen, LH itself, heparin, aspirin, prednisolone, and sildenafil. If you see heparin, aspirin, prednisolone, and sildenafil, they are actually helping agents or additional drugs which are used. They are per se not helping in supporting the luteal phase or the corpus luteum. So coming on to the main drug, that is the progesterone, it actually acts by improving the endometrial receptivity. It promotes the local vasodilation and uterine muscle silence by inducing nitric oxide synthesis in the decidua. It acts as immunosuppressants by blocking the helper T1 cells and inducing release of the helper T2 cytokines. So what are the types of progesterone which are used? They are mainly the natural progesterone or synthetic progesterone. In natural progesterone, it is usually the micronized form, and in the synthetic one, it is 17-hydroxydihydrogesterone capronate, that is also known as pronoton or maintain, or this dihydrogesterone, that is also famously known with the name of dufestone. So progesterone usually is administered in the oral form or vaginal or rectally, or in the parenteral form in the form of intramuscular injection or subcutaneous injections. If we talk about vaginal progesterone, why vaginal progesterone is preferred over oral preparations? Because vaginal progesterone, it provides the targeted drug therapy with the greater bioavailability with consistent serum levels, which may remain up to 48 hours than the oral progesterone. It utilizes the uterine first pass metabolism, thus minimizes the systemic adverse effects of sedation and weight gain. Now, if you see this chart, once the vaginal progesterone is inserted, after 4 hours of administration, there is progressive diffusion of the progesterone from cervix to the entire fundus of the uterus. Coming on to what are the vaginal preparations which are available. They are available in the form of micronized capsules, which can be given over a dose of 300 to 600 milligram over 2 to 3 dosage per day, or vaginal pessary. Same, again, the dose is 400 to 800 milligram over 3 to 4 doses per day, or vaginal gel, which is available in the form of 8% 90 milligram crayon gel. Gel is actually expensive, so you have to see the cost effectiveness of the procedure of the treatment as well. Then again, rings are available, which unfortunately in India they are not available right now. And these rings are usually available, usually administered on weekly basis, and they are as effective and safe alternative as the other vaginal forms are available. So there was a paper published, which was a systemic review when they compared the different forms of vaginal preparation, that is the capsule, gel, ring, or pessary, and they found none of all are equally safe and effective when luteal phase support is considered. Coming on to the oral form. Oral form is usually available in the micronized form, and it has higher, the disadvantages are it has higher first pass metabolism, the bioavailability is as low as 10%, and micronization decreases the particle size and shortens its dissolution time, and the side effects are sedation and anxiolytic effect, and of course the weight gain as well. Coming on to the other oral form, that is dihydrogesterone. Dihydrogesterone was actually first released as dufestone, and it is a retroprogesterone with a good oral availability, which has an anti-estrogenic effect on the endometrium, causing a secretory transformation. Now, the two landmark trials came out with this drug, and both of them, they proved that this form is equally effective as the micronized vaginal progesterone gel or capsule form, and the live pregnancy rates in both the cases were comparatively similar. So after a systemic review or meta-analysis released in 2018, it was concluded that the oral dihydrogesterone, it provides at least similar reproductive outcomes in the form of clinical pregnancy rate, live birth rate, or abortion rates, and it is a reasonable option. Of course, the choice of medication should be based on cost and the side effects. Coming on to the intramuscular progesterone injection, it is usually oil-based injection, thus provides a higher peak and longer lasting plasma concentration. The progesterone in oil is formulated with sesame oil, and 10% benzyl alcohol that functions as preservative, which actually causes pain in while administration. So the side effect is difficult to self-administer, are often painful, and may cause allergic reaction, inflammation, rashes, and sterile abscess. Coming on to the subcutaneous formulation, these are aqueous-based injections and are developed by encapsulating progesterone in cyclodextrin, which increases its water solubility. Upon entering the body, this gets readily digested and liberating the free progesterone. Advantage is that it can be self-administered and it is actually less painful injection. So when you compare different progesterone formulation, their routes and regimens, none of one progesterone form is superior to the other when comparing the live birth rate or ongoing pregnancy rates. Coming on to the next drug, which is very important in luteal phase support, especially in cases of fresh embryo transfer or in cases of IUI or recurrent pregnancy losses. So this HCG injection, it is actually to boost the production of endogenous estrogen and progesterone, and it is available in the form of intramuscular injection and subcutaneous injection. And it has been shown that the bioavailability of HCG injection is more when intramuscular administration is given as compared to the subcutaneous injections. So the complication is, of course, if there are a number of more than 3 dominant follicles along with intermittent size follicles, there is high risk of OHSS, especially primary as well as secondary OHSS. So when comparing the HCG with progesterone as a luteal phase support, none of one was considered as superior in increasing the ongoing pregnancy rate or live birth rate in assisted reproductive cycles. This means the ongoing pregnancy rates or live birth rate was similar when luteal phase support with progesterone was used versus HCG, or progesterone versus progesterone plus HCG. So the ongoing pregnancy rates and live birth rates were similar. So coming on to use of estrogen as well as progesterone in ART cycles. So when we see in long agonist protocol, adding estrogen can actually improve the implantation rate as well as pregnancy rate. However, in antagonist cycles, this addition was not very much beneficial. Later on, a Cochrane review was published in which they showed that when progesterone versus progesterone plus estrogen was used, there was no difference in the form of live birth rate or ongoing pregnancy rate, and none of one estrogen route, that is oral, transdermal or vaginal, was superior to the another. Coming on to GnRH and GnRH agonist injection, actually there would be this injection is actually used when you have an early luteal phase. This is basically a rare injection which is used in ART cycles, and the main purpose of this injection is just to rescue the corpus luteum and to support the embryo implantation, because it has been seen that early embryo, that is the morula and blastocyst stage, they actually have this receptor of GnRH, and it actually helps in implantation of the embryo. So this was the physiology behind which many ART centers, they were started using this GnRH agonist, especially in cases of FET cycles during near embryo transfer stage. So coming on to next, which is called modified luteal support. So what is actually modified luteal support? So when it was times when we were using HCG trigger in the ART cycles, and it was leading to high risk of OHSS. So later on in antagonist cycle, one theory came out that GnRH agonist trigger can be used to prevent OHSS risk. However, when GnRH agonist was used as a trigger, because of its shorter acting, there was decrease in the luteal phase support remained defective, and there was decrease in the ongoing pregnancy rate with a range of 2.9 to 20% only. So these poor results were attributed to the premature discontinuation of the hormonal supplements. So two approaches were suggested so as to support the luteal phase in cycles, especially when GnRH agonist trigger was used. One was American approach and the other was European approach. In American approach, both estrogen as well as progesterone was used till 10 weeks of pregnancy. And in European approach, along with the GnRH trigger, we were giving a double trigger with the help of 1500 international unit of HCG on the day of ovum pickup, and then after 5 days, again the HCG injection in the same dose of 1500 was repeated so as to support the luteal phase. So the dose of the HCG which is used is actually reduced in an attempt to decrease the risk of OHSS. So there were later on again different other regimes were also proposed, in which the daily smaller doses of HCG were given till the beta HCG report, starting from the ovum pickup date, or estrogen and progesterone as such supplement was given, or small doses of HCG were given at an interval of 3 to 4 days for 3 total shots. However, the risk of OHS was again higher in such a protocol. So what is the best timing of luteal phase support? If you see in after HCG injection, the luteal phase can be supported for 4 to 5 days. And once the pregnancy, once this HCG is used to support the corpus luteum, the corpus luteum starts producing progesterone itself. So there is a transition of around 2 days, after which the corpus luteum starts taking its role. So the use of luteal support becomes important in these particularly 2 days, starting from the ovum pickup and post ovum pickup of 2 days. So what is the best timing? So it was seen when the progesterone was started before the ovum pickup, it leads to decreased pregnancy rate as compared to when the progesterone was started after the ovum pickup. And the decrease of 24% of pregnancy rate was seen when the luteal phase support was delayed up to 6 days following the ovum pickup compared to 3 days following the ovum pickup. However, there was no difference found when the luteal phase support was started on the day of ovum pickup as compared to starting on the day of embryo transfer. So how long can we give the luteal phase support? So there is a transition of, there is a corpus luteal to placental transition, which usually takes place around 7 to 8 weeks of gestation. And this is the actually crucial time when you need to give the support so that this transition doesn't get affected. So as the corpus luteum increases in age, it produces HCG, it produces progesterone, and which supports the growing embryo. And when the embryo starts growing, the trophoblast starts secreting HCG itself, and this HCG then later on supports the corpus luteum, which again starts producing progesterone itself. So the transition we call, the important transition is seen at 7 to 8 weeks of gestation. So there are different papers which actually compared the luteal phase support starting from the ovum pickup, how many days after ovum pickup, until what gestation we should continue with the luteal phase support. And in different studies comparing varying time and dosage of progesterone, there was no significant difference which can be observed in helping clinical pregnancy rate or ongoing pregnancy rate or the delivery rate. But for practical use, we usually give luteal phase support, especially in ART cycles, till at least 12 weeks of gestation, after which we go for a scan. If the cardiac activity is okay, the growth is okay, we can still think of stopping the luteal phase support, as the pregnancy itself will continue and support itself. So the take-home message is, in natural cycles, the progesterone supplementation has no additional benefit in pregnancy rates. In recurrent pregnancy losses women, the progesterone addition has slight beneficial effect of improving the pregnancy rate. In IUI cycles, the luteal phase support doesn't result in significant increase in the pregnancy rate, except in gonadotrophin cycles or the latrose cycles. In ART cycles, the luteal phase support is must and should be continued, and no clinical difference in efficacy is observed in terms of the type of progesterone, its route of administration and dosage of administration. Intramuscular or vaginal administration of progesterone or HCG as drug for luteal phase support should be weighed according to the patient friendliness, cost, and side effects like OHSS. GnRH agonists can be used for luteal phase support along with other drugs. However, good quality evidence is still lacking to support its use. The duration of luteal phase support is still controversial. However, it is best to use at least till 8 weeks, and in practical purposes, we usually use till 10 to 12 weeks. In patients undergoing fresh embryo transfer with GnRH agonist as a trigger, intensive luteal phase support, that is called modified luteal phase support, is also required and mandatory. Thank you very much. I thank you all, and on the behalf of Valley Fertility Center team for patient listening.
Thank you, Anadip ma'am, for the lovely insights when you given regarding this very important topic, that is luteal phase support. With this, I call upon Ruxana ma'am to do her paper presentation. Ruxana ma'am. Before going ahead to Ruxana ma'am, so she is Dr. Ruxana Farooq. She is MBBS, MD, DNB, Ops and Gynae. So ma'am, over to you to take it forward, ma'am. Ruxana ma'am, are you there?
Yeah, I'm there.
Please.
Hello. Good evening.
Yeah, ma'am. Yeah, ma'am. Please.
Good evening. Hello.
Yeah, good evening, ma'am. Good evening, ma'am.
I'm Dr. Ruxana Farooq. Thank you so much for allowing me to present the paper in your webinar. Do you listen me?
Yeah, ma'am. You are audible, ma'am.
Okay. I want to present the paper. The topic is correlation of cervical pap smears with histopathological diagnosis in cervical lesions. As we know, cervical cancer is the most common genital cancer in India. In India alone, 130,000 new cases occur with a death toll of 70,000 every year with cervical cancer. The objective of current study was correlation of pap smear with histopathological diagnosis. A retrospective study was conducted in the tertiary care hospital in 130 sexually active women. Pap smears were taken and histopathological diagnosis was performed in all such patients. From pap smear findings, out of 130 patients, maximum number of cases, 56.9% were categorized. Hello?
Yeah, ma'am. Carry on, ma'am. You are audible, ma'am.
Audible, ma'am.
From pap smear findings out of 130 patients, maximum number of cases, 56.9% were categorized as epithelial cell abnormality. Atypical squamous cells of uncertain significance was seen in 10.2 patients. Low-grade squamous intraepithelial lesion was seen in 13.1% patients. High-grade squamous intraepithelial lesion was seen in 8.5% patients, and squamous cell carcinoma was seen in 1.5% patients, and adenocarcinoma in 0.8% of the cases. From cervical biopsy reports, 51 cases were diagnosed as chronic cervicites, 26.2% were diagnosed as chronic cervicites with squamous metaplasia. Cervical intraepithelial neoplasia, SIN first in one was diagnosed in 23.8% patients. SIN2 in 8 patients, and SIN3 in 3 patients. The sensitivity, specificity, positive predictive value, negative predictive value, and accuracy of pap smear test was 91%, 82%, 73%, and 94% respectively. Now, carcinoma of cervix is second most common cancer among the women worldwide after breast cancer. Cervical cancer is the most common genital cancer in India. In India alone, almost 130,000 new cases occur with a death toll of 70,000 every year. Ours was a retrospective study conducted in the Department of Obstetrics and Gynecology scheme, SORA, Srinagar, over a period of 2 years from March 2019 to March 2021. A total of 130 patients were selected that had undergone pap test and cervical biopsy. Detailed clinical parameters like leukorrhea, pain lower abdomen, menorrhagia, postcoital bleeding, and intermenstrual bleeding were studied. The pap smears were taken with air spatula, spread on a glass slide, and fixed immediately with 95% alcohol. Staining was done using pap stains. The cervical biopsies and hysterectomy specimens were taken from the same patients. Their cytological reporting was compared with the histopathological diagnosis. The inclusion criteria included sexually active women with complaints of leukorrhea, lower abdominal pain, postcoital bleeding, postmenstrual bleeding, and menorrhagia. Now, a total of 130 patients were taken in the study, with most of the women being in the age group of greater than 45 years. And most women were in the clinical profile of being multipara, with parity of 3 found in 42% of the cases. The most common chief complaint among patients was white discharge per vaginum in 48% of the patients, pain lower abdomen in 28.5% patients, and postcoital bleeding in 10.8% patients. Now, in our study, maximum cases were in the age group of greater than 45 years and 40 to 44 years. The results of our study were comparable with other studies. In our study, it was seen that out of 130 patients from pap smear findings, maximum number of cases, 56.9% were categorized as negative for intraepithelial lesion malignancy. And out of epithelial cell abnormality, atypical squamous cell of uncertain significance was seen in 25 patients, that's 10.2% patients. From cervical biopsy reports, out of 130 specimens, 39.2% were diagnosed as chronic cervicites, 26.2% as chronic cervicites with squamous metaplasia. SIN1 was seen in 23%, SIN2 in 6.2%, and SIN3 was seen in 2.3%. Malignancy was seen in 2.3%, out of which squamous cell carcinoma was seen in 1.5% of the patients. From our study, strong correlation was found between pap smear findings and cervical biopsy reports, thereby confirming the role of pap smear test in screening of cervical lesions. The pap smear screening, the pap smear screening should be carried out in all sexually active women. Pap smear is cost-effective, easily available, and non-invasive method of cervical cancer screening. It has excellent correlation with histopathological diagnosis. Therefore, it should be encouraged as effective tool for cervical cancer screening program to reduce the incidence and mortality caused by cervical cancer. The study was approved by the Institutional Ethical Committee schemes, SORA, and there was no conflict of interest and no funding sources were used. Thanks a lot. Hello. Hello.
Sir, you are mute. Sorry, you are mute, sir, mute.
Anadip ma'am, are you there?
Yes, I'm there.
Yes, ma'am. So, ma'am, thank you, ma'am, for giving us an opportunity to get associated, ma'am. So that was a beautiful topic you talked upon, ma'am. So
Thank you very much.
we always, whatever stands committed, ma'am, in such kind of scientific conclave or scientific thing, and in future also we like to be associated. And thank you, Ruxana, ma'am, for
Thank you
this
so
lovely
much
topic.
for
Thank you,
giving
ma'am.
valuable opportunity to present my paper in your webinar. I'm looking forward for more presentations through your webinar. Thank you so
Thank
much.
you, ma'am. Thank you, ma'am. Our pleasure,
you.
ma'am. Thank you. Wishing
Thank
you all a lovely evening ahead, ma'am. Thank you, ma'am.
Thank you so much.
Thank you.
Um,